So we're going to take questions from the audience now, and I want to remind you of two things. Please make your questions brief and directed, and also please speak up. Amanda sent an email earlier today saying that she was having trouble hearing the questions. So imagine yourself speaking overseas to Amanda.
My name is Bill Hazard. I spoke earlier today about being a geriatrician and gerontologist. My name is Bill Hazard. I spoke earlier today about being a gerontologist and a geriatrician and fascinated with people 85 and above. But I also want to make very clear that this has been a strange week for me because I'm spending my evenings reading Jared Diamond's latest, The World Until Yesterday, reviewing all the kinds of things you've been talking about and wondering which is the best. But that I'm here today pursuing it is fascinating. But I come back to opportunities and making it very clear that we are dealing with sort of the crisis in American healthcare, much of which is within the American healthcare system. And there are major things that can prevent infections, like washing your hands, like sterilization, all the rituals, yes, but there is a point. All of the rituals that can prevent infections. But once you start treating them, then you get all the problems of the antibiotics. So let's not forget that there's a huge benefit to not getting infected in the first place, and there's a lot of return on changing the system toward that. But the question is, how about if we look ahead in healthy 85-year-olds? These are the people who have succeeded, and we could examine their microbiomes because they have proven that they can live in American society. Most of them are women. Obviously, we need to examine that. But there are population studies being conducted. There are population studies being conducted in 80-year-olds prospectively in the Baltimore Longitudinal Study of Aging and also in the Women's Health Initiative, which can address now. Yeah, okay.
Is there value to looking at the microbiome or asking these types of questions in healthy people that are 85-year-old and older? Is that your understanding of the question? Thank you. Amanda?
I'm scratching my head a little bit. I am aware that there is a study of the microbiota in older populations that shows some interesting changes, that they as a group have a different microbiota from sort of younger individuals. I apologize, though, I can't recall off the top of my head what those changes are. So people are looking at this question. But again, it's hard to tease apart some of the cultural factors that are in play there too. How many of these people, for example, are living in institutions where they are eating food that is prepared communally? How many of these people are on drugs for various medical afflictions? So these kinds of questions need to be teased apart as well. But absolutely, these people have survived in Western societies, and presumably we have a lot to learn from their microbiota.
So we just have a few minutes more for questions. Would you guys like to take more questions? They have a diversity of... Yes, so in the back, please.
In University of Nebraska Medical Center, College of Nursing. Thank you very much for this panel and the integration with the previous panels. I'm struck... first of all, I wasn't sure I would even like this program, but it's really powerfully challenging my thinking. When you said the germ theory and penicillin, my God, that's where medicine's secure professional scientific foundations developed through the last 100 years. So this is both an opportunity for systems paradigm shifts, but it's probably also very threatening to a lot of people. Have you thought about how the multidisciplinary, the systems approach, the biomes of communities, and how we keep wanting to reduce things down to a variable and very predictable, how those things conflict, and or advice for us in health professions about opening up our paradigms?
Do you want to take that question?
Sure. I think, so I think medicine needs more biology, and particularly more evolutionary biology. That would be my one sentence. I think there is, in biology, have sort of indicators if you're on the right track or not, and that's based on whether something makes sense evolutionarily. And if it does, then it's likely to be a correct hypothesis. There is I think the important aspect of what your question is the balance between the scientific progress and the dogmatic aspects of clinical science that have their own good reasons. But I'll just give you one quick example, and that has to do with application of evolutionary thinking to healthcare. And that has to do, again, with the issue of antibiotics. And as we all know, when you are prescribed antibiotics, if you do need them, you're asked to take the entire course of whatever, a week or 10 days. And there's absolutely no scientific reason for that. If you're taking antibiotic and you feel better after 2 days, there is no reason to take it for the rest of the course. And the reason there is for that is that if you already killed whatever was susceptible, you're done with your, from the perspective of treating the disease. If there are rare mutants that are resistant to antibiotic, then by taking it for the entire week, you help them to take hold on the system. You promote selection of resistant antibiotics by doing that. This has been shown definitively through mathematical modeling by Andrew Reed, who is an evolutionary biologist from Penn State, who demonstrated that very clearly in multiple publications. And of course, physicians will keep prescribing antibiotics for the entire course. That is completely randomly decided for random historical reasons. That's one example of how dogmatism in clinical care can go a long way without making any scientific sense.
Great. So I think we have time for one, possibly two more questions. And do one of you have a question that would be great for Justin to respond to?
Carlos Del Rio from Emory University. I don't know if it's for Justin or for you, but thinking about the built environment, the diet, how we cook things, it seems to me like where those two things collide is when we institutionalize people. We have people incarcerated, we have people in long-term care facilities, we have people in nursing homes. So what do we know about people who are in set built environments? They're all the same, and set built diets, they're all eating the same. What happens to their microbiome when they come from the outside? Does that decrease diversity? Can we increase their diversity? What can we do?
That's a great question. So I have given thought to the microbiome in healthcare facilities, and particularly how can you design and operate healthcare facilities to mediate the risk of nosocomial infections. But it had never crossed my mind, and I've also thought about prisons and the schools and the other environments that you're talking about, but it has never crossed my mind that in some systems you automatically have embedded this framework where people are in the same built environment and they're eating the same diet. So I don't know anybody who has thought about it in this light, and I think that that's a brilliant question.
I guess.
Okay, great. We have time for one more question.
First, I wanted to compliment Amanda on her statement that this is curious and interesting. Those were excellent words. I will commend her on that. Ruslan, can you comment for us? The take-home message earlier was, how are we translating this? And I think Dr. Stern was trying to say, is this ready for prime time in the field of obesity, for example, or in changing our nutrition as a second example? What would you say to us today for the clinicians in this room and for the take-home message?
I think
yeah, I think that's an excellent question. I think there are things that are ready for that are becoming ready for the prime time. I think we see this with fecal transplants. This is the first indication that we can reprogram the microbiota to positively influence health. We saw an example of a study earlier showing that you can reprogram the microbiota with fecal transplant to influence metabolic syndrome, although over short time periods. So I think, and from what I've heard, there are about 40 or more clinical trials underway for fecal transplants in various scenarios. And then many other ways of thinking about this as well. So thinking about treating the microbiota with a small molecule drug, thinking about using microbes that are engineered for doing specific things. And the horizons for these are different lengths of time, but I think, you know, we saw a really compelling story with the TMAO example that Stanley Hazen shared. I think that, you know, there are going to be these things that are going to be the leading edge of the field, and then pretty soon it'll be incorporated into medicine, and this will happen over the next, I would say, you know, 5 to 10 years, and you'll be seeing it in the clinic.
That's a great note to end on. So thanks for a wonderful panel.